So Dr. James is a paediatric haematologist from Leeds Children's Hospital, although she was raised this side of the Pennines. Dr. James is also the secretary of the paediatric group of the British Society for Bone Marrow Transplant and is really interested in data and evidence-based medicine. Dr. James is also on the My Life team looking at a range of impacts of chronic blood disorders, including educational and socio-economic impacts, as well as health and problems. Okay, Dr.
Brilliant. You might want to just come forward, just because my writing is beautiful, but it makes me a little bit too small. So thank you so much for inviting me to speak today. It's a real pleasure to be here with you. So I just thought we'd start off, and we are going to just have a fun kind of flip chart presentation. So where are we going together in the next hour? So just so you've got some kind of framework, I thought I'd just give you the kind of the headlines that I'm going to talk to. So the first thing is the context. And that's really the context of sickle cell disease in our population. Then I'm going to think about what is haplo transplant. And I know there's a range of expertise in the room, so my apologies to those of you who've been doing haplo transplants for donkey's years, but I just want to make sure that everybody is covered. The next thing we're going to think about is what about haplo transplant in sickle? And this is a tricky sentence for me because, you know, we've got Greek here merging into Latin, so it's kind of, anyway, I just thought I'd mix it up. But we've got, so Sakari obviously is where we get sickle cell from because you cut grass with your sickle, and Sakari is Latin, whereas haplo obviously is that. But I think many is Drapan. Yeah, so that's what we would call it if we were being properly Greek. Anyway, and then lastly, we're going to just think a little bit about balance. So, you know, how do we try and balance, in the one hand, your transplant, and in the other, your conservative options, you know, your red cells exchange, your hydroxyurea. How do we try and balance up which is best for our patients? So, first of all, we said we'll think a bit about the context of sickle cell disease. So can I just pause there for a minute, Eva, and just check that everybody is reading this okay on the screen? No one's putting messages in chat saying this is ridiculous, we can't see anything.
No, really see
Lovely.
context of number one.
Very good, okay. So you spend a lot of the day thinking about the context, the background of sickle cell disease, but it does really bear thinking about just the multiple systems and end organ damage that this cohort experience. So if we just think about one area, for example, CNS, and I've chosen this because, you know, all of you sitting out here with your lovely faces, you know, our brains are very important to us. And I just wonder if we would settle for the kind of CNS complications that this cohort have to settle for. So the lovely paper by Fenella Kirkham in Blood in 2016 that looks at the sickle complications, really good review paper. And what you see is you see 39%, so that's almost all the patients have silent infarcts. Silent infarct by 18 years of age. I think that is really, really startling and really distressing, actually. The next most common complication is headache. I wonder how many of you, when I wrote the word headache, just kind of downgraded that as a complication in your mind. Because I think often there's a real disconnect between what our patients think is important and what we think is important. And these guys who've heard me waffle on about this for a long time, you know, as medics, as nurses, we love vomiting. We love vomiting because we can count how many vomits, how many mils, what colour is it? You know, we can really get to grips with it. Nausea, not interested. Vomiting, we can treat. Nausea, you know, we can't measure it. But actually, for most of our patients, or many of our patients, it's less distressing to vomit than it is to feel nauseated. So headache, really important complication. But if you have migraine, you know how distressing it is. So actually, headache acute and chronic is the second biggest complication.
Let me make sure we're all on mute. Just make sure that everyone's on mute, please, just so that there's no back channel. Okay, we should be good to go.
Next complication, ischemic stroke. Now, we do rightly talk about the gains we've made. Ischemic stroke we now expect to see with screening in about 1%, and that's down from 11% without screening. But it's still 1% having a stroke. Hemorrhagic stroke, again, with screening, it's right down to about 1%, to about 3%, and that's down from 10%. But remember, this is children, because we don't have still a great screening strategy or way of preventing the morbidity and mortality in adults. It's a very different situation in the adults. And again, I don't know how many in the room here are paediatricians or paediatric work in the paediatric sphere, but it's really incumbent on us as paediatric doctors to think about where our patients are going for the rest of their lives. Because often they look very healthy when they're with us, but we do them a disservice if we don't think about what comes next in their lives. But obviously, it's not just their brains. You know, I could have talked about any of these: lungs, the heart, kidneys. The renal complications are terrible. You know, about 16 to 18% of deaths in sickle cell are because of renal complications. About 1 in 8 will have irreversible renal disease, and that becomes apparent usually in the 3rd decade. Well, again, that's just not acceptable, is it? It's really, really difficult to hear this. What about the bone complications? Again, bone complications, you know, we're now moving into thinking about surgical things. We kind of switch off a little bit. Orthopedic, we switch off. But AVN, very distressing. If we couldn't do the lovely, healthy things that we'd like to do, you know, we'd be very upset. And then you've got the thrombosis. You've got the pain. You've got all the quality of life. And this all feeds into quality of life. And you've also got, increasingly, we see it as a pre-malignant condition. And there's a lot of data coming out about the high increase in AML and in ALL in sickle cell disease. That's really, really important. So all this leads to lots and lots of morbidity and mortality. And the big figure here is 20. You know, most studies that look at this show that you will live 20 years less than your peers without sickle cell disease. So if you just now suddenly add 20 years on to your age, you know, it's quite salutary. Or you think of how long you think you might live and then take 20 years off and see the gap between where you are. You know, it's not a great outcome. And again, if you look at this, want to look at that in more detail, I'd commend you a paper in JAMA last year by Patricia Kavanagh, which looks at a lot of this kind of data in a very rational, very measured way of looking at that. So this is the context that we're looking at. Okay, so this is why it's important to do something about the life expectancy and the quality of life of our patients. The next thing I want to think about is transplant. So that was a bit to go for me because obviously I'm not day-to-day doing haemoglobinopathy, but now I'm much more into my comfort zone talking about stem cell transplants. So stem cells, remember, these are hematopoietic stem cells. These are the cells that will then be able to make your red cells, your white cells, your platelets. And so what is a transplant? Now, not everyone here is a transplant, so I'm just very quickly going to whiz through how I see transplant. So in transplant, you have a bone. This is the kind of comedy bone that you see in cartoons that we've watched since we watched things like Scooby-Doo as a child. So inside the bone, you have your stem cells. All your stem cells here. They're making red cells, they're making platelets, they're making white cells. They then go out and they become the blood cells. Problem with sickle cell disease is that you have sickle cells, stem cells that will make sickling red cells. So what you can do is you can give chemotherapy. Goes in like that. And then normally when we give chemotherapy for something like a leukemia, we're not actually aiming to kill the stem cells, we're just aiming to frighten them a little bit so they stop working, and so that the blast and leukemia stem cells will be killed, but we're not actually aiming to kill them. But in transplant, we're aiming actually to wipe out those stem cells. So that's great, because now what we have is we have somebody who is no longer making sickling red cells. Except they're actually completely empty, so it's not a very good situation. So in this situation, you're going to have to give them red cells, you're going to have to give them platelets, and you're going to have to give lots of antibiotics, antifungals, antivirals. Can't leave something like that, nor do you want to. So you want to have some lovely stem cells here from a non-sickling donor. They run in, just like a blood transfusion, a platelet transfusion. And these have an amazing thing on them. They have a little sat-nav system, the stem cells. And it is like that, you know, most of us have watched those documentaries of wildlife where you have the wildebeest migrating over the plains. And that's what happens. These go into the blood and they just swarm through the blood. And they have this message. They have two messages or two commands they have to follow. The first is, quick as you can. This is what the mother stem cell says to her little child stem cell. Quick as you can, darling. Get into the blood, find yourself a little niche inside the bone marrow. So they get inside, as soon as they can, they are there inside the stem cells, inside the bone marrow. The next thing they're primed to do is once they've found a little home inside the bone marrow, they have to start making blood. So they go, right, okay, safe inside the bone marrow. Mum said must make some blood cells. So then they start making the blood cells. And then, hey presto, you now have blood which doesn't sickle. So that is what we're doing in transplant. We're replacing the immune system, the whole hematopoietic stem cell system. We're not just changing the red cells. Now, obviously, this is fraught with complications. I don't know if it's because your talk was about endocrine things, but I'm now having either a hot flush or else the heating. I don't think it's just me. I think it is the heating. That would be great. Okay, so thank you. So that's a transplant, but actually here we're talking about haplotransplant. So what is a haplo? When we're talking about a haplotransplant, what we're talking about is the donor, okay? So it refers to the donor. That's what the haplo bit comes from. And we're matching on the immune system, essentially. We're matching on HLA class 1 and class 2. So you'll hear people talking about A, B, C, DR, and DQ. We look at DP sometimes, but we're not too bothered about it. Remember, you get half from mum, half from dad, so actually you get 2 different potential loci at each of these. And that's what we're matching on. Now, to minimise your complications, you want the best donor, the best matched donor you can have. So we either look for a matched sibling donor, and these are the kind of terminology you'll see us using in transplant world, or a matched family donor. Matched family donors we find quite often in the thalassaemia population where there's a lot of consanguinity, but we don't tend to see that in our sickle cell population. So we very rarely find a matched family donor in the sickle cell population. So you might then go on and look at a matched unrelated donor, and there's millions of people in the registries worldwide. Or we have what you refer to as alternative donor. And I'm just going through these terms because we fling them around, but sometimes you don't know quite so what they mean or where they come from. An alternative donor really refers either to cord stem cells, umbilical cord blood. You can remember when you've got the little baby kind of in utero like this, with its little arms there, you've got the cord and the placenta, and that's absolutely full of stem cells. So sometimes we might store those to get cord blood, either on a public bank or by doing it in a directed way. Or we have haplo. These 2 guys we're trying to match in all 10 of these places, 2 A's, 2 B's, 2 C's, 2 DR's, 2 DQ's. To the registrars out there, if you struggle to remember which D's it is, I always used just to remember that DP is dippy, and so that's the one that you want to ignore, but you might have a more sophisticated way to remember that. If so, please do use it. So with haplo, just to recap on our inheritance. So say mum is like this. So say she's, just for the sake of argument, we're going to call all of this going to be summed up into a big A. So that's her half. That's her half from mum, that's her half from dad. Dad got that from his mum and that from his dad. Okay, so when they have children, the possible combinations for their child might be an A and a C, an A and a D, She's probably chosen different letters. These A's have nothing to do with those ones. Or a B and a C and a B and a D. Now, say mum's got a sibling and her sibling is a F, then actually this person is haplo-matched, half matched with that person, and half matched with that person. Mum is half matched with these two, and mum is also half matched with those two, and dad is half matched with this one. So all these different combinations are half matched. That one there is matched with that one, it's matched with that one. You've got one going to there. So you can also get uncles. The point here is that you might have a sibling who's a half matched transplant, you might have a mum or a dad, or you might have an uncle or aunt who's a half match with you. So we're likely to find a half match in a family. And that's important because actually matched sibling donor, you only find that in sickle cell in less than 15% of patients with sickle cell will have a matched family donor. And that's because we have much smaller families this in this day and age, but also because you might have a perfect match, but it might also have sickle cell, in which case obviously that's no good. And because the registries are so swayed towards the Caucasian population, your chances of a matched unrelated donor, if you're Caucasian, are about 80%. If you're with sickle cell disease and you're from global majority heritage group, it's likely to be about less than 20%. So there's a huge niche here, and actually one of the Nolan's aims in the next 5 years is to increase the donor pool from those from global majority heritage groups. So I just said, for those of you who didn't miss it, that actually your chances of transplant outcomes are better the better your donor. So why are we talking about suddenly going from a 10 out of 10 to a 5 out of 10? It's a little bit odd, but it's because we haven't got anything in between, because we really struggle for that middle group. So what are the complications that we're thinking about? And again, I'm just going to go through a few of the terms here that we use, because we throw them around, but sometimes, you're sitting there thinking, so a bit of audience participation. What parameters do you think you would like to know? What outcomes do you think are important if somebody might be going through a transplant? Just shout it out, put your hand up, so your friend told you to say it. I don't mind. Mortality, yes. So what is the overall survival? So overall survival, that's a common parameter not studied. Really important. Anything else? Fertility, yes. You want all these things like, how is their life going to be afterwards? So long-term outcomes, late effects, really, really important. We're going to come back to that. So I'm very pleased John mentioned those. Secondary malignancy down here as well. Now that is very important, and we'll mention why that's particularly important in sickle cell disease. But then you've also got your acute things. So you've got your graft versus host disease, where the new cells arrive, but they start attacking the new body because our immune systems are trained to be very xenophobic and to think of anything foreign as a threat, and so to attack it. We spend that first part of our lives educating our immune systems about, this is me, don't attack it, this is me, don't attack it, this is me, don't attack it. So then we tend to think different and go, that's not you, better attack it. But obviously, we're now introducing a whole new immune system. They've got to learn what's me, so they don't attack it. So we want them to wake up and go, oh, it's very nice in here. I think I'll just settle in nicely. We don't want those new cells to wake up and go, foreign, must be bad, better attack. That's not what we want, and that's graft versus host disease. Can be fatal, they can be very, very serious. Can be acute or can be chronic. Chronic is when it occurs over after 100 days, broadly speaking, but it also depends on the kind of features you see. And the two other really big ones are infection, either because you haven't got neutrophils because it's before engraftment, because you're suppressing the immune system so that it doesn't cause GVHD, but then you're more likely to get an infection. And the other big one is that actually you get relapse. Relapse in this context means that your disease has come back. And that is one facet of graft failure, which is something that we dread. Well, we dread all of these things, actually. Transplant is a really rewarding specialty, but it probably ages you at twice the rate of your peers. So graft failure. Graft failure may be primary or it may be secondary. So primary means it happens By day 28, there was no grafts, happens very early. And secondary is when it just kind of peters out as time goes on. And we're more likely to see that in conditions like sickle cell and thalassaemia. We've got this very hyperactive bone marrow. And so we're trying to give as little chemotherapy as possible so we don't get all the toxicity. But then that means we might be eradicating the stem cells, and your own will always want to come back more than somebody else's.
Like psychological trauma.
Yep.
Is that?
Yep, I think all of those are down there.
I know that Claire had something to say about Claire.
Oh, I think it's all been said now, but thank you.
Thank you.
Oh, thank you. So we put these through now. You'll see often in transplant papers that we often refer to these as GVHD-free, relapse-free survival. And this is now one of the big outcomes. So two of the big outcomes looked at in transplant papers will be your overall survival and your GVHD relapse-free survival, because we want you to be alive and well enough to enjoy being alive. So that's just a bit of
Is it worth
background.
just adding about the failure to correct the secondary problem? So if somebody's got chronic pain or they've got
Yes.
an underlying neurological complication of sickle, those things may or may not improve.
Yes, and actually one of the things we are seeing now is that we used to think that transplant just held things as they were, but obviously you might have damage still caused, the fire has gone through the house, you've still got the damage that it's left behind. We are actually now seeing improvements in a number of different end organ damage. So we're seeing improvements in pulmonary hypertension, we're seeing improvements in cardiac function, seeing improvements in the neurological imaging, we're seeing some of the cognitive decline being halted, even reversed. But there will be, not everything will improve. And it's really important when you're counselling families that you're very honest about the fact that actually you're not suddenly going to be made new. And I think one of the things that's really important for people probably outside of this group to grasp is that because we look after these patients on wards very often where many of the people caring for them are also caring for patients with leukemias and cancers, it's very, very different. It's very different to be well or have a child who's well, who then becomes ill, who you're hoping to restore to health again, to having a chronic progressive condition. It's a very, very different beast. But we take all of these very, very seriously because at the end of the day, we're the ones who have to look the families in the eye, look the young people in the eye when it goes wrong. So I think years ago, people were maybe more gung-ho in transplant. There may well still be some gung-ho transplants out there, but I think most of us are actually very measured. We don't transplant because we find it fun. The night before any of my patients come in, I'm there thinking, is this the right thing to do? Is there anything I've forgotten? Is there anything we should be doing? Because you have to take it seriously, because even if 1% isn't surviving, then that 1%, if that's your child or that's you, then that's everything to you. So we have to take these very seriously. Okay, so we thought about transplant, thought about the complications. How do we actually do haplo transplant if I've just said that you have to have a really well-matched donor to make it safe? Well, the key thing is that you have to take out the T cells somehow. You have to have some kind of T cell depletion strategy, because it's your activated CD4 cells particularly that will cause a lot of the complications, whether it's the rejection, and so you don't get graftment, or whether it's the graft versus host disease. So there's two main strategies for this. And all across the world, people tend to be in one camp or the other. So I'm going to try and be very even-handed in the way that I talk about this. But apologies if I'm not. So here is a donor, okay. And the donor, remembering their bone here, this is their femur here, they've got all their stem cells. There they are. So they're going to have an injection of GCSF 4 times, and that is going to move their stem cells into the blood. We can then stick in a big cannula here, They sit in a machine, it comes out, we spin it round, red cells at the bottom, plasma at the top, take out a little bit here of the white cells on a continuous basis, into the bag goes stem cells, mix it back up, goes on the other side. And so they just sit there and we just take away the peripheral blood stem cells. So that's what we used to do. Peripheral blood stem cell harvest. So now you end up with a bag like this. In this bag, you've got your stem cells and you've got your lymphocytes. Well, we've just ascertained, haven't we, that we don't want the lymphocytes because they're the thing that will cause particularly the devastating features. So people did do transplants where they gave this like that back to people. And obviously you've got absolutely horrendous GVHD and you got a lot of death. So not acceptable. So let's remove the lymphocytes. Well, maybe let's not remove lymphocytes. Maybe let's select out, because what we really want are these things. So then they thought, well, let's CD34 select. So you have a column here, and you can put little beads in. And these beads love anything with a CD34 marker on. So you put this bag through here. You're going to stick all the stem cells to the side of the column, and you collect bag 1. Bag 1 is full of lymphocytes. Throw that away, let NHSBT do all their ethically approved studies that you consent for in 2B. And then once that bag's gone, you simply wash through a little bit of preservative, and into bag 2 here, you now have bag 2. Don't mix them up. This is the one with just your CD34 selector stem cells. So then we started trying to give those to people. What we found is that you got very, very little GVHD. You got very rapid engraftment often because you could get super doses. But what you did get was you got a lot of viruses. And the death from viruses, particularly things like adenovirus, is really unacceptable. These days, we have much better treatments for adenovirus and CMV particularly, but the deaths were unacceptable. So CD34 selection, some people came through like that, but it wasn't a great strategy. So the way we now do peripheral blood ex vivo T-cell depletion is like this. We have our stem cells and we have our lymphocytes. Then we realized that actually there are essentially good lymphocytes and bad lymphocytes. Although that's probably, I don't know if that's not PC in some way, but you have your alpha beta lymphocytes and you have your gamma delta ones. Okay. What we realized is these are the guys that cause the GVHD. And very helpfully, these are the guys that are particularly good at fighting viruses. So what we now do is rather than selecting out the CD34 cells and keeping that bag, we take away the bit we don't want. So we put it through a column, a black for a column, put through a column here. And this has got your alpha beta cells. And so these lymphocytes, they just get stuck in there. And in your bag at the bottom, you have your stem cells, but you've still got the lymphocytes that you want to have because these are the gamma delta ones. And so when you do it like this, which is called alpha beta depleted, or alpha beta depletion stem cells, what you're going to get is you get very, very little GVHD because these guys have gone, but actually you don't get the viruses because these guys are still there. So that's how we can do a haplo transplant, by taking these T cells out before we actually give it to the person. Yes, go ahead. No.
If it's fine to have 5 out of 10, I mean, why do you need any matching? Can't you just give any stem cell?
Well, that's a very good question. And we're wondering, why do we, exactly that, could you just give from anyone? But people haven't quite made that leap, and we're still trying to persuade, people into this. So a lot of these are actually essentially passers-by, So the other strategy is post-transplant cyclophosphamide, PT-Cy, and that's how you see it written down in lots of shorthand. So PT-Cy, this is very expensive. Don't tell anyone. This is my lead colleagues, please don't tell anyone this, but it costs about £24,000 to do this in the lab. You just delete that bit of the recording. Very cheap. I have over here, it's very cheap. But the thing is, you're giving a very pure product, is the point. So actually you're giving a very, but this is essentially cheap as chips, because we get cyclophosphamide is a very cost-effective way of doing it. And so this is many more experience in this worldwide, because you can do this very quickly and very cheaply. So with post-transplant cyclophosphamide, you have your person here. Now this person is lying down, and you're taking the bone marrow out here. Okay. You can do it with peripheral blood as well, but usually it's with bone marrow. Now, what you don't want is those CD4 activated T cells. So you now have your bone marrow product here, and it's full of all kinds of gubbins. You know, you've got stem cells, you've got the old red cell, the platelets. Hopefully you've filtered it so you don't have any grist, although we discovered one centre recently that wasn't always filtering, but doesn't seem to have any problems. Anyway, lymphocytes. So on day 3 and day 4, you get this massive surge of the T cells. And you are there ready and waiting for them, okay? So it is just like you're waiting for them to come over the hill, and then you go in with cyclophosphamide. Cyclophosphamide is particularly directed at CD4 cells, and it will also later encourage, around day 21, development of your T regulatory cells, which you need later on. So you give this on day 3 and day 4, and it will wipe a lot of those out. And it doesn't wipe out the stem cells. I still find this really that you're giving chemotherapy after you're given these precious stem cells, and then you're giving chemotherapy. But this works, and this is really popular. But this is so popular now it's becoming standard in any mismatch transplant 9 out of 10 transplant. So, but what you mustn't do, a few things, just what we're talking about, is you don't give any immunosuppressive treatment beforehand. Now, I'm not talking about serotherapy in conditioning. Serotherapy is just, you know, we always like to try and confuse people by talking about words that you didn't want to mean. So transplant is about serotherapy, but essentially it just means ATG or Campath that you give in conditioning. I'm talking about sirolimus, tacrolimus, cyclosporin. What you don't want to do, they're like the snipers. Think of those guys as being like sniper fire, okay? So you don't want the snipers to be out there, because the T cells will then partially be knocked off and the army will recognise what you're doing. You want to keep it really quiet, let them get right out, and then launch the cannons, which is cyclophosphamide. Wipe out as many T cells as you can, and then introduce snipers to pick off any that's left. And so then on day +5, that's when you can start either your calcineurin inhibitors, cyclosporin and tacrolimus, possibly MMF, or you might use sirolimus. We use a variety of these depending on your centres. So a few fun facts. So these are your calcineurin inhibitors. Some centres still use cyclosporin as their treatment of choice, their calcineurin inhibitor of choice. Tacrolimus is much more popular in North America, and many centres it's got a better toxicity profile. Tacrolimus sounds like sirolimus, but actually it's very different in terms of its action, its class action. But they've got a similar derivation. This is just a little aside here. I've got enough time for an aside, yes. So tacrolimus comes from the, it's invented in Japan, or found in Japan, identified, grown from Streptomyces in fermented broth in Japan in 1987, which coincidentally was the same year they discovered Alps. So in 1987, they identified tacrolimus and found it was very immunosuppressive. And because it comes from Streptomyces, they named it in the same way they had already called sirolimus, although in fact it's a calcineurin inhibitor like cyclosporin, which sirolimus isn't. Sirolimus also comes from Streptomyces. You also grow it from Streptomyces, which is found in the soil. Sirolimus was found much earlier in 1972, which is before some of you were born, but not everyone in the room. And so sirolimus was found from Streptomyces soil from Easter Island. And does anyone know the local name for Easter Island? Rapa Nui, Ben says. Yes, so Rapa Nui. And so you can see we call sirolimus rapamycin. It comes from Easter Island, which is called Rapa Nui. Isn't that lovely? So it's a little fun fact about the I think it's very nice. So finally, guys, we're now talking, we've got to the stage where we can actually talk about Haplo in sickle cell disease. Okay. These guys are now shocked because I never write SCD, because I think SCD is a horrible way of writing sickle cell disease, but I haven't got space. Because I never know, do people mean you've got SC, or do they mean you've got SS? Or it's a horrible thing. So you should never write that and then just put cross by actually, because I'm horrified at what I've done. So always write sickle, please. Otherwise, people might be confused.
Never heard of anybody being confused by a sickle, but okay.
Because do you mean you've got HBSC or do you mean you've got HBSC?
Sickle cell disease.
No,
You've got
very, very distressing. So the first transplant, I'm just going to say a little bit words here about sickle and transplants. The first transplant in somebody with sickle cell disease in 1984. But it was only done because they had AML. And although it completely took away sickle cell disease, there was still a big gap before we actually thought, you know, sickle cell disease has such horrible complications, we should actually do something about it. We just noted how interesting it was they didn't have sickle anymore, but we didn't go, wow, maybe this is something that could actually really help. And in 1984 was the first transplant for sickle cell disease. Nowadays, with matched sibling donors, which this talk isn't about, we're seeing if you're under the age of 6 years old, a 98 to 100% overall survival and a sickle-free survival at that in matched sibling donors. And then, as I just mentioned earlier, the big thing we're seeing is the end organs. And so if you can transplant children under the age of 10, we're actually seeing a reverse in some of the end organ damage. And that's one of the big things that's different from gene therapy, because in gene therapy, you're not giving them a recognised phenotype. You could argue that people have hereditary persistence of fetal hemoglobin. But actually, there's a reason why we switch from fetal hemoglobin to adult hemoglobin when we're born. And that's because of the oxygen affinity. And so there's increasing concern that if you give people a hemoglobin that has an oxygen affinity where you've got a poor delivery of oxygen to your end organs, you may just be delaying end organ damage. So gene therapy may have potential in many groups, but it isn't maybe the superarching answer to everything that we were hoping for. We have to be measured about these advances. Anyway, we're talking about Haplo here. So the first Haplo transplants were reported in 2012 by, and if you look at the paper, it's by someone called Bolaños Mead. And it was using something that is referred to, again, in things, people refer to protocols by the paper. So they're saying, oh yes, the Baltimore protocol, oh yes, John Hopkins. This is the John Hopkins Haplo protocol that they used. You give ATG, give flu, a bit like we do for aplastic patients. We've tried to reduce often the toxicity of chemotherapy in sickle transplants because they already have multiple comorbidities. And then you throw in some TBI. This one was 2 gray of TBI because we think that reduces the graft failure, which I'll talk about in a minute. And then they were using the PT side because that's what most people did. We didn't really start doing the alpha depletion until the sort of 2015, 2016 was when it began to really get some traction. And what they did is they reported 14 patients, and these patients were 15 to about 42 years old. Now they had 100% overall survival. But those overall survival, remember, they weren't all, we're also thinking about disease. Now 8 of them had graft failure. And so they demonstrated the principle that you could give a relatively low toxicity without giving such awful treatment-related morbidity and mortality that killed people, but it wasn't entirely successful because not everyone ended up with a sickle-free future. And that, I think, is in Lancet Haematology, but you can just look at, it's not a common name, so if you look it up, you'll find that. And then after that, there were more and more papers coming out and basically just improving in different ways. So not long after that, in 2013, there was the first proper paediatric study. But in this one, there were deaths. And so now there was a big move forward to say, how can we try and, you know, keep this survival, but reduce the graft failure? And so over the next, I'm not going to take you through all the different studies, but over the next few years, basically what happened was they experimented with the PT-Cy dose. And Courtney Fitzhugh is somebody who's done lots of work on this, if you want to look up her papers. And now we've really settled on this 50 milligram on day 3, day 4. And that's very standard. Even in very small people will be using that. They increased the TBI dose. So we don't really understand what TBI is doing, but it seems to be that if you give some TBI, it just sort of cleans the ground and you get better engraftment. Now, most of us have used TBI in the context of ALL, and we think of it as something that you would really want to avoid at all costs. And so I came into this, and still do, feeling very alarmed and worried about using TBI. But one fraction of TBI is a very different thing to giving 12 Gray and 6 fractions, or 14.4 Gray and 8 fractions. So it went from 2 Gray to 3, and some people even will use 4 Gray, but that's where it gets capped. And as you go up, you see better engraftment. And the other thing we did is we increased the immunoablation. So again, increasingly in the world of transplant, we don't just talk about myelosuppression, we talk about immunoablation, because we're trying to reduce the risk. So we want the immune system to be gone as far as possible. And one of the big ways, there's 2 big ways we've done this. So the first is with Thiotepa, and Josu de Fuente down in London had a paper out where he showed that in a group of 15 paediatric patients, he had 100% overall survival by adding Thiotepa and only 1 graft failure, which works out at about 93% sickle-free survival. So you can see now we're kind of moving into where we want to be. We're still keeping that overall survival, but we're reducing the graft failure.
Can I ask a quick question? I mean, if you've got graft failure, do you then also avoid all the other complications? Like,
Well, if you've got graft failure, you're not going to sickle because you haven't got, it depends how profound your graft failure is.
yeah.
One of the things that really worries us in transplant about graft failure is that, we increasingly understand sickle is pre-malignant and that you will get clonal hematopoiesis. And so if you're not careful, so if you have a situation where you've got graft failure and you might get great autologous reconstitution, so you might just be back to where you were and that's all fine. But if you've got a poor graft function, that bone marrow is going to be trying really hard to repopulate the blood, and it can't do that very effectively. So in that situation, you've got a much higher risk of developing clonal hematopoiesis. If you have clonal hematopoiesis, you have a much higher risk of going to get malignancy. And that's one of the reasons why the Bluebird bio trials were paused, is because of this big concern that actually you may be pushing the dial towards people getting some kind of mild malignancy in particular, because you've got clonal hematopoiesis, because you had graft failure. So you've got to really, apart from that, you can't let people just stay in that position of having no bone marrow. You've got to be very careful that you manage it very carefully. So again, if you have mixed chimerism, that might be fine, but it's not fine if you've got poor graft function at the same time, because anything that's going to make that bone marrow work harder is a real risk to those patients. And the other thing, so that's been our kind of UK strategy. The other thing is pre-transplant immune suppression, and this has particularly come out of Thailand and India, and is really changing the face of transplant in thalassaemia as well, where you give cycles either of just Flu-Dex or a Flu-Cydex, and traditionally for the last 4 years, you give 2 cycles, about 6 before transplant, 3 before transplant. Because we said that you get graft failure, because we don't want to give huge amounts of immune suppression. So that kind of limits you, but actually then people said, well, hang on, why don't we just give it staggered? One of the reasons why we think patients with malignancy don't get the graft failure is because actually we spent, months or years just constantly attacking them with chemotherapy. So maybe actually it's better for some of these patients when we think there's a very high risk of graft failure to give them something immunosuppressive and reduce their bone marrow function, give it alongside hydroxycarbamide in some situations, and see if you can then get your graft failure up. So that's the other strategy that's been improved, that's been used. And with this, in the big Indian paper, they got 100% engraftment. We've just had our first patient using that protocol of pre-transplant suppression, and I was very alarmed, thinking, oh no, she's going to come in with awful infections. But actually, she tolerated it so well. It was really striking. So that was the kind of direction of Haplo. And we're just going to look briefly at the Haplo meta-analysis, and then on to my last piece of paper, Haplo meta-analysis. So this was a Irfan, who's a Dutch chap who works a lot in transplant, was the author of this paper along with people like Josu, and it came out in 2020. And so I'm just going to give you the headline figures. They looked at 179 patients. And this included in 2020, it included all those early papers that I was telling you about where actually there were deaths because we were very much learning how to do it. So these figures hopefully will be getting better than they were. But they found a graft failure rate of 7%. And those patients then either going on to having their backup autografts giving themselves back, or they'll be having a second transplant. They found an acute GVHD rate of 4%. They think that maybe this might be slightly increased in the alpha beta group, but they're not sure. They found a chronic graft-versus-host disease rate of about 11%. And then what that boiled down to, the figure we really want to see, is an overall survival of 91%. But the more recent papers actually showing a much higher overall survival in Haplo. And in the UK, we have a meeting every October where the paediatric group get together for what's called our national audit, or which we know informally as the national confessional, where every paediatric centre presents every child they transplanted the previous year, and another centre will audit all the data. And we will challenge one another, or people stand up and say, because the doors are closed, nobody's recording it. People will say, I've had 3 cases of this. What have I been going wrong? This is what I did. And people will say, well, why did you give ATG and not campaign? People will challenge each other, and we learn a lot from that. So, in the last few years, we've seen a lot.
So it's like 9% deaths.
9%. That's the overall meta-analysis worldwide in the closed collection in about 2018. But in the last few years, things have been getting better. So look at the UK. Between 2017 and 2021, there were 20 haplos in the paediatric population, of whom 19 are alive. So that chimes much more with our more recent experience that we think the actual survival in paediatrics is probably upwards of 95% in haplo transplant. So that really brings me back to my kind of question about, well, how do we decide? So that's where I'm going to end up. So we think possibly more acute GVHD in the alpha beta, but that's now kind of begun to be questioned because we're seeing virtually no acute GVHD in our alpha beta cells. We think maybe there's a difference in this. We're not sure. What we really need is a head-to-head. There is a head-to-head going on, but the problem is that because centres are wedded to either alpha beta depletion or to PT-Cy, the head-to-head is of centre versus centre rather than in one centre. So it's not controlled for everything, but it's the best we've got. So there'll be 4 UK centres taking part in that: Newcastle, Leeds, Birmingham, and St Mary's. And it's already going on in the rest of Europe, but not surprisingly, we've had a lot of regulatory issues setting up in the UK. But they're both good strategies. They both have benefits, but it would be really nice to know which is better. So how do we decide? How do we decide which is better or at all? And that's a really hard question. Well, we have indications. So we have the EBMT indications. If you just Google BSBMT indications, we come up with the paediatric table, which is where we've tried to think of all the things that you might transplant for and then work out when it's a standard of care, when it's a clinical option, or when it's just not recommended that you transplant with that kind of donor. So lovely table and grid in that. But we still don't really have an answer. And the thing that constantly, every time we look at this, is that what we really need is the patient voice. And this is an area where there is so much paternalism. And it's good that I'm about to stop speaking. Something that really drives me mad is that we do not hear enough from the patient group themselves. Not because they're not speaking, but because they're not being listened to and not being given the opportunities to represent themselves very often. So there was a big need to gather information so that we can inform. And so I just wanted to end up with just a few slides, because actually I do also know how to use PowerPoint. just in case you're wondering, just to show you about something that we're doing across the north of England and further afield to try and provide some information that will help us with that. So my beautiful system is just going to switch now onto the PowerPoint. Does it come from presenter mode?
That's a quick clinical question before we look at the visuals. I mean, obviously, so I'm an adult hematologist and this is very different in adults, but one of the, when we discuss who should be going for transplant, quite often it'll be people who are untransfusable because of antibodies. Can you, to what extent can you do a haplo transplant without transfusing people? That doesn't sound possible.
So there is a new kid on the block with transplants in sickle, which is the chemotherapy-free protocols that have been developed in the National Institute of Health in America, and which have now been validated and study after studies. So this is the Solomon protocol we're talking about, where you don't use any chemotherapy, you give CAMPAS and you give a fraction of TBI, and then you suppress with sirolimus as soon as the cells are in. So the toxicity from that is very, very much reduced compared to everything else. And so in that, you might be able to get away with almost no transfusions. But the difficulty is if you can't transfuse sickle cell patients because they've got antibodies, that group's in really high risk of graft rejection and graft failure. So, they've already, it's too late, as it is with, many situations. So this is just a few words about something that I hope will help us in the future work out what to do. So the My Life Consortium is we've got a grant of just over £500,000. So one of the NHS medium strategies has been to look at prevention, health and equality, a strong start for children and young people with cancer. And so in Leeds, one of the big things that we like to do is we have a lot of interest in big data. And so we also have a long-standing interest in late effects. We all know that it's much easier to fund things in cancer. All their work's been developed in cancer and in that world, but we're now leapfrogging onto that. And so LEADER, the Institute for Data Analysis, have got a whole infrastructure where they can look at the hospital health service utilisation, comprehensive primary care, mental health, education. And you just do these great linkage analyses where you can just look at all these data sets and interrogate them to actually see how people are doing. So we have funding to look at, in our first phase, leukemias, which is how we got the funding, but also to look at serious hematological diseases, Thalassaemia and Sickle cell disease. So I am so excited about this. It is going to be really beautiful. So we're looking at the long-term impact of these diseases in the UK population, variations in healthcare needs, the relationship between different pathways, and then the impact of clinical practice variations. And that includes things like being transplanted or not being transplanted. So in practice, what we're going to be doing is looking at some things across the north of England, some things across the whole of the UK. So looking at survival rates and life expectancy, and the National Haemoglobinopathy Register are really supportive of this, which is lovely. So you can link lots of things once you have the villagers talking to each other. So in the north of England, and hopefully the whole of the UK, it looks like we'll have about 12,500 sickle cell patients that we're looking at in this, and just under 2,000 thalassaemia patients. For some of these, we'll be looking just in the Yorkshire population, and in the Yorkshire and the North East and North West population, we're looking at about 1,800 sickle cell patients and 400 thalassaemia patients. So really good numbers. What we've done is we've taken a cohort who already reached adulthood, so we can look at how they all were. So that population born who've progressed to adulthood, how are things for them? So we're looking at all the HES data, look at what happens in terms of health utilisation, looking at the costs of the subsequent health service, and looking at whether transplant is cost effective, whether it has an impact on their health service needs in the future, but also really important, looking at mental health outcomes. So all these things are often on scene, but in the big data sets, but that we know day to day really have an impact. And looking at age and sex matched peers, which we've got data from looking at in all the cancer patients. Looking at educational outcomes, which again is really important, going right through into further education because there's huge data sets on this. And then we can look at other social outcomes. And then there'll be a whole lot of proms that will be advertising and recruiting people to look at, particularly looking at employment and relationships and reproduction. So I'm really excited about that. Hopefully that data will start coming out in about 3 or 4 years' time. We've got all the analyses in. And that I hope will then just mean that we've got more information to give our patients so they can tell us what they actually want to do with things. So thank you very much for inviting me to speak.
Is there now any questions in the Chat, so we have Marnie who said an amazing presentation, many thanks. Are there any questions? Chat, yeah.
Like you touched on, obviously, the gene therapy. Obviously, we've got the first one that Chris was sort of going through a review at the moment. Really nice. You touched on how he thought it might potentially impact on outcomes. I think it's nice that we potentially are going to be able to give families choice and options. But I think it's going to become very, very difficult to give them the information and help them.
Yeah.
What's your opinion on it as to which groups you think may potentially benefit more from the gene therapy and which ones you think will potentially benefit more from that?
Yeah. Well, if we think about sickle, because sickle is the ideal gene therapy target because you've got a monogenic disorder. The thing that struck me is we've got a consortium of people around the world who are particularly interested in sickle transplants, thalassaemia transplants, gene therapy. And we met last November. And so all the big names in gene therapy were there. And they were saying, this is not yet a cure for sickle cell disease. And it was really salutary because often people have been really buoyant in that group. And I think there's now just beginning to be a bit of like, it's not quite all that we hoped it would be. And particularly the issue of, well, what is the long-term impact of having fetal hemoglobin? So there's a cohort study they're going to be doing looking at those who've got HER2 persistence, just as in America, they're doing an exciting sickle cell trait study. I guess it might be for the kind of patients that Naomi was just talking about, where you're not transplantable because it's too late, but you may be able to have gene therapy. We're as I alluded to, we're now doing transplants without chemotherapy with much, much lower toxicity. And gene therapy, you still have to have chemotherapy. It does have impacts on fertility. I think there's something about the word gene therapy that sounds almost kind of cozy and sort of straightforward and easy. I don't know what that is. It's kind of the way we've all been sort of, brought up to think, oh, this is just something you do, just change a gene, and there we go, it's all better. And actually, it's not quite as straightforward as that. So I think it absolutely will have a place. But I think that the worries about clinical hematopoiesis and the worries about the effect of fertility are not insignificant.
That's it. Thank you so much. So that concludes today's event. I would just like to thank everyone for coming, especially those speakers and those who have travelled far and wide to attend. And thank you to the online attendees as well.